Thank you for listening to this PYA webinar recast. PYA is pleased to offer this alternative way to access our thought leadership. This is a recording of a previously delivered webinar. The information is accurate as of the date of the original event. The video recording, slides, and associated material for this and all PYA webinars are available on our website at pyapc.com. This podcast is for educational purposes only. It is not intended to be used as legal advice or an official opinion.
Good morning, everyone. PYA is pleased to welcome you to day one of our third annual Summer CPE Symposium, Hot Topics in Healthcare. I'm Catherine Good, a leader in PYA's Audit and Assurance team. PYA is happy to present these complimentary virtual learning opportunities to healthcare colleagues across the country. Over 2 days, PYA thought leaders will present 4 sessions on trending topics and provide key takeaways and helpful tools for you and your organization. Today's presentations are Medicare Reimbursement and Effective Cost Reporting, and Insights from the DOJ, Management Accountability for an Effective Compliance Program. With that, I'll hand it over to our moderator.
Thank you, Catherine. Our first presentation of the day is Medicare Reimbursement and Effective Cost Reporting, presented by Emily Wetzel, Director of Reimbursement here at PYA. And with that, I will hand it over to Emily.
Thank you, Caitlin. I'm so excited to be here. One of my favorite topics, cost reporting and reimbursement. I'm a director here. I lead our reimbursement services here at PYA, where we do a lot of cost reports and other reimbursement-related consulting projects. My background is in Medicare and Medicaid cost reporting, Medicaid mostly. I'm located here in Charlotte, North Carolina. So coming from the East Coast, I know we have a lot of viewers across the country, so I'm really excited to be here with you today and look forward to any questions that you submit through our panel on the GoToWebinar section. And with that, I'll do a quick recap of what we're going to talk about and kind of how our presentation is going to be scheduled today. So first, we're going to start with PPS hospitals. As you all know, there's certain areas between PPS and critical access hospitals that are different and require some different tools in your toolbox to have a proper and effective cost report. So our first section is going to be around PPS hospitals, but note that some of these areas that we're going to discuss today may be applicable to both types of hospitals. And so I'm, just for the ease of, we only have 1 hour today, we're trying to break it out into some easier concepts to take in and use at your organization. So we'll start with PPS hospitals. We'll continue on through some critical access hospital reporting, provider-based clinic areas as well. And then we'll wrap up the presentation today, around some tools that you can use or things to think about once you have your cost report prepared. Can you use this data for something else besides just the compliance portion of filing your cost report? So we'll walk through a few key metrics and areas that you could take into your organization to help you as a user reuse some of this information that you're required to pull every year from Medicare. So why not use it in a different way? So first, for PPS hospitals, you're required to prepare a wage index section. So we're going to start here. And so the Medicare certified short-term IPPS hospitals are required to complete the wage index schedules, which is worksheets S3 parts 2 through 5 in the Medicare cost report. And that's done on an annual basis with your annual cost report. There's also an occupational mix survey that's done every 3 years that also pulls in some additional information from your facility, but that's only due every 3 years. And that was last due last summer, but we'll get into that a little later. The wage index values, as you know, are incorporated as an element of your Medicare reimbursement. It goes into the labor portion of your payment from Medicare, so it's a very important piece of your payment. And so, if you have significant changes in those factors, that could affect your reimbursement. The goal of the wage index from our perspective is to adjust the prospective payment rates, like I just mentioned, to account for varying wage-related costs in your hospital based on where you're located geographically. So, for example, I always like to use extreme examples. If you are a hospital in New York City, the wages you pay your employees are going to be much higher than a hospital located in rural North Carolina, which is where I'm from. There's just going to be some differences, and so Medicare wants to make sure they take that into account when paying. These geographical areas are defined by the Office of Management and Budget, and they're called core-based statistical areas, or CBSAs. So if you don't know that name, I think we have probably a variety of skill sets. So if I may go into something that you don't know, but please ask a question if I go through something and you're just unsure of what we're talking about. So your wage index worksheets are commonly reviewed in detail by the hospitals, by you, or your third-party provider before CMS conducts their annual wage index audits. So for federal fiscal year 2026, your wage index values will utilize hospital cost reports beginning on or after December 1st, 2023. And revisions to those worksheets are due to the max by September 3rd, 2024. And as you know, there's a whole schedule. The federal fiscal year 26 timetable has been released by CMS. So your max are going to be looking to adhere to that schedule. So this summer, when you have, if you have downtime, I know that's always the case, you're always busy. Make sure that either your team internally does another detailed look at your wage data, or if you have a cost report preparer, an external third-party preparer, typically they can provide that review as well. But that's always beneficial to make sure that you're getting have the most accurate information in your cost report. So you just want to make sure your dollars and hours are also supported for the MAC audit. So another key piece is not only is that data correct in your cost report, but making sure you have the proper supporting documentation so that when the MACs are going through their audit, you want to make that as easy as possible for them because their requirements come from CMS. And so they're just trying to get their job done and make sure that they're following their rules. So having, your proper documentation to support all your numbers is also very important. So as we mentioned before, this data is used to adjust Medicare payments for differences in wages across the states. It's applied to the labor portion of your Medicare payment. And also the hospital index data trickles down to other providers. So if you're thinking about the skilled nursing facilities in your geographic area, a rehabilitation hospital, a home health agency, or hospice services that are being paid by Medicare, your wage index data as a hospital is being pulled into creating your wage index value for your geographic area. That's going to be used for those other providers as well in their payments. So for example, so if you're in a county or CBSA area where there's only a few hospitals and you're not critical access, you're an urban area, you could be negatively affected if another hospital in your group, it's a small group of hospitals, if someone has an error in their cost report or isn't filing the best data for their wage index, that could affect you. And so I've actually worked with some systems, and I've worked with systems all over the US where they were competitors and they ended up working together to make sure that their wage index data was correct because they would all be affected by each other's wage index values. So I thought that was pretty cool. Of the community coming together to make sure that they had the proper wage index amounts. So with COVID-19, I hate to keep mentioning it, but that is continuing to see some influence on these wage index numbers. So from our perspective, we saw a lot of additional contract labor through those years, just trying to fill staffing positions. Some hospitals had multiple nursing groups that they were working with. And so that we're seeing that kind of phase out a little bit where they're actually able to hire more employees and using a little bit less contract labor. So there's definitely been some flux the last 5 or 6 years in how what you're paying for staff. So I think we'll continue to see the effects of that at least another year or so. So some of you on the call may be more impacted by a rural floor. So the rural floor was initiated to protect small CBSAs from having a lower calculated wage index that was below the state's rural wage index. So the floor is where you would be, guaranteed having your wage index. Certain urban hospitals that are granted a reclassification through the MGCRB to rural will be included in the rural classification in fiscal year 2024. And in the proposed 2025 rule, CMS plans to update the CBSA definitions, delineations that were issued by the Office of Management and Budget based on the 2020 census data. So moving into some other areas that affect your wage index would be physician data. This is an area that I see where there's always room for improvement. Some hospitals do a great job, some struggle with it. And they may not struggle because it's a difficult area. They struggle maybe because their physicians are hard to keep track of where they are spending their time. Maybe they're not filling out their time studies or timesheets correctly. So the thing you want to really keep track of is for these Part A, Part B physician times, keep a time study. That's probably the best practice. Or timesheets where a physician will fill out a percentage of their time or the number of hours where they spend doing administrative work, were they in a meeting, were they in a quality meeting, where they start seeing patients, directly seeing patients. So understanding how they're spending that time is critical to having that broken out in your wage index. And so those are the types of things that your MAC is likely going to ask for to support those numbers in your cost report. And so the MACs may also ask some additional information around your physician data. So keeping track of this throughout the year versus right at the end or at the time of audit when you're already, so far removed from that time period and having to go back and go to the physician and say, hey, how did you spend this time? It's good to keep track of this ahead of time. So the type of personnel, the description of the services that they rendered, labor costs, what are you paying them, their related hours, and also the trial balance number of where those expenses are going to be, are coming up in your trial balance. And then from there, from your group trial balance, what cost center that they're showing up on in the cost report. So contract labor, some hospitals may have a ton of contract labor to keep track of, and that can be quite a monster sometimes and take some time to sort through that. Some hospitals may not utilize as much, and so it's a little bit more straightforward. Typically, I'm not going to say always because I think MAC's handled a little bit differently from side to side. They may request all contracts that you had in place for this labor during the cost report period to support your dollars and or hours for those individuals. And they may also request individual invoices to support those numbers. So we recommend always keeping track of these contracts throughout the year. So it's not just one department or group having to retrieve all of these contracts during the audit. That can become pretty time consuming for a group. And the MACs, CMS requires the MACs to be on a pretty tight deadline for these wage index audits. So the easier you can make this for your MAC auditor, the easier your process is going to go. There are also some new software programs out there. If you have a lot of contract going on for your organization, there are programs out there that can assist with organizing and tracking contracts for multiple reasons. And one being the wage index request. From our perspective and what we've been hearing from some of our clients, dietary contract labor has been asked about a lot over the past couple of years, especially if you include a small number. Maybe it was related to like a catering job or something where it's not really the whole dietary department, it's just kind of a piece of it. What they're looking for dietary contract or in the salary position on your wage index is they're looking for the whole department. If you're outsourcing your entire dietary department, You want to include the dollars for that department to outsource and the hours for those individuals who are working your dietary department, even if they're outsourced. So take a close look at that and make sure that those numbers are accurate. So kind of in general, when you're tracking your contract labor information, keep track of your vendor's name, the description of services provided, because that helps your preparer, whether internal or external, know which line to put that contract labor dollar and hours in. There's different lines for different types of contract labor, or maybe it's a type of contract labor that's non-reimbursable and it should not be included at all. So keep track of that, and also keep track of which GL accounts that expense is hitting to know where those expenses are hitting in the trial balance or on Schedule A, which we'll get to in a little bit. And the final thing, and if there's no hours that you can document or support for your contract cost, those contract costs must be excluded. If you don't have the hours, or there's no way to support the hours for that individual and their expense, that expense must be excluded from your wage index. Wage-related costs, there's a section for this piece on the wage index. You know, there's some differences between if you're self-insured or if you have a third-party administrator. If you have a third-party administrator, the TPA report may be requested by the MAC to support these costs. And typically, when you start with finding these costs, you start with the trial balance. Typically, there's some, what we usually see are GL accounts for these wage-related costs. We start there. If you're preparing internally, you want to make sure that what's included in those counts are all wage-related costs. But you also want to consider, are there any wage-related costs in other accounts included with other expense items, such as things that the hospital may provide to employees at no cost or at a discounted rate. So if you're providing vaccines that are not covered under their insurance, free or discounted smoking or weight management programs, or physicals that are not covered under insurance, those are the types of things that may be able to be included with your wage-related cost. So kind of going through the wage index audits related to your MAC. Just overall, again, you may benefit from having a second look at your wage-related costs. Maybe at the time of filing, you weren't able to do that deep dive that you really would like to do. So some suggested items that we have seen that's been helpful for some of our clients is having a comparison to other hospitals in your same CBSA or surrounding areas. Are you way outlier? Are you way higher than the rest of them, or are you way lower? Sometimes there could be some good to look into that. Reviewing your prior year adjustments from your wage index audit. If your auditor is finding the same adjustment year after year, you should go ahead and just make that change so that there are less adjustments that the auditor has to deal with. You want to make this easy for your auditor. It just makes everyone's life a lot easier. They're trying to help you guys. A 3 to 4 year comparison of your key wage index numbers. So if your overall average rate per hour increased like $10 an hour, something's fishy there, and you want to take a look at it. It could be correct. Maybe you're using a lot more contracted labor that's more expensive, but sometimes it could just be an error. Maybe you didn't pull a line, or you're accidentally including shift differential hours that shouldn't be included. So just doing that is also very helpful. And include other hospital departments in your conversation. Tell them what your goal is. The goal is to complete your wage index schedule accurately and bring in the payroll leaders or the accounts payable leaders to help you with the invoice side. So involving more people in the conversation can help make the process smoother in some cases. And I think I mentioned a couple of these throughout our discussion, but on-call hours, shift differential hours is a common error that we see. They're accidentally included. Maybe they're in a column that accidentally was included with the paid hours. Not having full support for your physician Part A administrative time, accidental omission of dietary or housekeeping contracted hours, benefits buried deep in other accounts, and then alignment of wages and hours. So if you have an A6 reclass where you're moving salaries from a reimbursable or overhead overhead cost center down to a reimbursable or non-reimbursable cost center, are you moving those hours, or are those hours being artificially inflated because you moved the salaries, but you left the hours there? That's a common area we see that you can look at. So just briefly, the occupational mix survey is completed every 3 years. Some of the categories included in this are RNs, LPNs, nursing assistants, orderlies, surgical technologists, and these are going to be your full-time, part-time, or directly hired or contracted employees. You're not going to include any hours or salaries for physicians or APNs that are directly billable under Part A or Part B. So the rural wage index score, CMS estimates that 646 hospitals will receive the Rural 4 in fiscal year 2024. And this Rural 4 has to be applied in a budget neutral manner. And so you want to they make sure that the wage index for an urban CBSA code cannot be lower than the state's rural wage index. So if you're in a frontier state, I think I saw a couple of registrants, however you say it, from a frontier state. So your wage index floor is set at 1, and this does not have to be applied in a budget neutral manner, like we saw on the previous slide for the rural 4. So with that, we have our first polling question.
Thank you so much. The first question is, what best describes your organization's wage index status? And the options are urban CBSA, rural CBSA, frontier state CBSA, onshore or other, or I am not a healthcare provider. And remember, you must fill out the polling questions to receive CPE credit. Thank you for participating in our poll. Now I will hand it back over to Emily.
Thank you, Caitlin. So moving on, I know many of you may already know this and kind of have that impact, but I wanted to make sure we covered kind of just an overall look at how your Medicare cost report reimbursement works. And, this flow that we're seeing here is the same for prospective payment system and critical access hospitals. So the way that you're reimbursed kind of in that section E at the bottom is a little different for critical between PPS, but really the A series, the B series, this is all going to be pretty much the same for both types of hospitals. So since critical access hospitals are cost-based reimbursed, we're going to cover more of the details of what to look for and some of the opportunities in the A series, B series, and C series a little later on. So we have a quick look at this, but then we're going to move into more of the PPS settlement items that would be more relevant to that type of hospital. So the DISH uncompensated care payment, this program was established in 1986 to provide additional reimbursement for hospitals that serve a disproportionate share of Medicaid eligible and uninsured patients. So prior to 2014, it was 100% empirically justified DISH. So we all know in 2014, there was a breakout of this where 25% was the empirically justified DISH and 75% is now for uncompensated care payments. So your uncompensated care payment, if you qualify for these payments, it's a product of a few factors, and it's been a transition over the years. And also the addition of the S10 worksheet has also provided some data to CMS to help with this calculation with some published numbers that they publish each year. So a hospital's uncompensated care payment is relative to the uncompensated care amount of all the DISH hospitals expressed as a percentage. So there's a pool of money that's being distributed out to all of the hospitals. And as we all know, that pool of money is getting a little bit smaller each year. So you may have seen the effects of that, or maybe you haven't if you're qualifying for a larger percentage of that pool. So eligibility for 340B, which is pretty big, is directly linked to your allowable DISH percentage. So making sure you're paying close attention to that DISH percentage and how it's moving each year is very important. If it's greater than 11.75, you qualify for DISH or you qualify for your 340B. I had a hospital that I worked with kind of in the beginning, not the beginning, but earlier in my career, and I was not in charge of this one, but their DISH percentage was at 11.75 with all their additional days. And they lost their payments because it has to be over 11.75. So they lost their 340B program. They lost a lot that year because of that. And I think the next year they were able to find some additional days through a DISH review, and they were to get back. But it was pretty significant for that hospital. And so my heart went out to them because that was a big impact for them. So community hospitals, you can qualify for 340B with a greater than 8% allowable DISH percentage. So this kind of depicts the primary method for qualifying for DISH Medicare payments. I'm not going to go through this, word for word. We're not here. I don't want to do math here today for you guys. I wanted to give you more of the concepts, but if you're looking at your total Medicare days, your total patient days, your Medicaid and non-Medicare days, if there's any big changes or swings in those, if you've had lower volume, this is going to really affect your DISH each year. So, understanding what your volume levels are throughout the year could be helpful to help estimate at the end of the year, well, what am I going to get back, or am I going to have a big payable at the end of the year because I've been paid more than I was owed. So a few DISH-related updates. There was, in the final IPPS rule, there was some more commentary on Section 1115 waiver days. And so CMS has now limited how Medicare 1115 days can count for the purposes of DISH. So the final policy will only count the days of patients who receive the state's Section 1115 demonstration if they have health insurance that covers inpatient services, or they have premium assistance that helps cover 100% of their insurance, which also covers their inpatient services. So something to think about when you're looking at your Medicaid DISH listing that you're going to have to provide, and counting those days for your DISH payment is going to be a little bit different. There's some more information on how that should be handled. And also this transmittal, the treatment of Medicare Part C days, and hospitals with cost reports on hold, where there's been no NPR that's been issued, or hospitals with pending appeals, your DISH adjustment could be affected. So our recommendation at this time is just to reach out to your MAC to see what your next steps would be. So again, there's going to be some crossover between the PPS section and the critical access section. And so this is one of those crossover areas. So both types of hospitals, all hospital cost reports, are eligible for claiming Medicare bad debts. They're claimed at 65%. And so some of the things that are allowable and not allowable, I was just going to walk through those really quick. So allowable bad debts are debts that are related to covered services derived from your deductible or coinsurance amounts. You must be able to establish that reasonable collection efforts have been made and that the debt has been deemed worthless or uncollectible. You use sound judgment to make a decision that there's no likelihood of recovery at any time in the future. So non-allowable bad debts, I feel like I get this question a lot, which is okay. I think it can be a little confusing, especially with more Medicare Advantage plans being offered in the marketplace. But deductibles and coinsurance amounts from patients enrolled in Medicare Advantage plans, or professional fees billed separately, or for services not covered under Medicare, are non-allowable bad debts for the purposes of being reimbursed on the cost report. So keep that in mind. We have a couple different types of bad debt: traditional, crossover, and indigent. Your crossovers are your patients that qualify for both Medicare and Medicaid. Your regular traditional listing is are for patients that are eligible for Medicare, but are not eligible for Medicaid. So Medicare bad debts also may go through an audit process with your MAC. So a lot of times, things to think about is that MACs may ask about your recoveries. Recovery is a little bit more difficult. We found from talking with other hospital providers, they can be a little challenging to support sometimes, but also making sure you keep copies of your bad debt policies because they may be requested. The audit may have a process to identify any dissimilar treatment between Medicare and non-Medicare accounts, so just something to keep in mind. And they also may take a sample of your Medicare bad debts, and if they find that there's a lack of documentation throughout the process, they may take a percentage of your bad debts received. They may take some of those back because they're not confident that your listing is accurate based on a sample selection. These are just some of the things that may happen. And as many of you know, there's a new format for exhibits. So Exhibit 2A for filing your Medicare cost report, you have to use this new format, or your cost report may be at risk for being rejected at the time of filing. It's recommended. Many of you have probably already been through this process. So you just want to, and some of you may not have. If you're a 630 year end, your time is up next to make sure you have these new forms filled out appropriately and completely. So go ahead and get your internal team together and make sure you have a plan together before the deadline to ensure that there's adequate time to pull all the information from the fields. What we've heard is that data is having to be pulled from maybe 2 or 3 different systems and kind of compiled all together. So making sure you understand that process and have someone in charge of that, someone owning that is going to be really helpful at your deadline. A few other considerations. Bad debt amounts should not include professional or fee schedule amounts. Check for duplications, use formulas to check for duplicates. Payments were not netted against accounts, including amounts that were previously claimed, and not including all the required data on your Exhibit 2A, like leaving some important data out could run the risk of a rejection. So in addition to the new form for Medicare bad debts listing, is exciting because for us cost report people, you know, we get like one big update a year. And so this is our big update, and we're going to keep talking about it until it's not important anymore. And maybe we have the next big update. So there's 3 additional exhibits that you'll need to complete this year if you are if any of these are applicable to you. So Exhibit 3A for your Medicare eligible days. If you're claiming DISH or any lip payments, you'll need to complete the schedule. Charity care for S10 and total bad debts listing for S10. And the one thing I'll say about that is make sure you have some type of reconciliation from your GL or financial statements back to your total bad debts listing. That's something that we've seen be asked for the MACs and can sometimes be a little challenging, especially now with the new listing that's required. So with that, we have polling question number 2.
Thank you, Emily. The next question is, if you have compiled the new exhibit requirements, how did it go? The first option is easy, no issues. Slightly challenging, but next year will be easier to pull. Very difficult and time consuming. My organization has not yet filed our fiscal financial year 24 cost report, or I am not a medical provider. And remember, you must fill out the polling questions to receive CPE credit. Thank you for participating in our poll. Now I'll hand it back over to Emily.
Great, thank you, Caitlin. So our last little bit on PPS related settlement areas is that you may be qualified to be a Medicare dependent hospital or receive low volume adjustments. So just some updates there. For MDH program, as we all know, we think it's going to end and then it gets extended at the last hour. So currently the program is extended through the end of this year, December 31st, 2024. They're located in rural areas, have less than 100 beds, and are not classified as a sole community hospital. For your low volume adjustments, if you qualify for those, there are some changes on the horizon with this adjustment. So starting in fiscal year 25, they're reverting back to the fiscal year 2011 standards or qualifiers for the low volume adjustment. So with that, you'll have to have fewer than 200 total discharges and located no more than 25 road miles from the nearest hospital. And as you remember recently, those qualifications have been a little bit more lenient, I guess is the right word. You could have more discharges and the road miles was a little bit shorter. So definitely some changes there in the horizon for that payment. So keep that in mind when you're budgeting and looking to the next year. So with that, we're going to move into our critical access portion of the presentation. And again, some of these topics that we talk about here will also be applicable to PPS hospitals, but I included them here because since critical access hospitals are cost-based reimbursed, some of these areas are not more important, because everything's important, more critical and have more of a direct relationship with the cost-based reimbursement for a CA. So if you're a CA, you're located no more than 35 miles to the nearest hospital or other critical access. It may be a little bit different if you were grandfathered in through the state certification of being a qualifying hospital. So I think that was prior to December 31st, 2005. You furnish 24-hour services, no more than 25 beds. You're reimbursed by Medicare at 101% of hospital allowable cost for inpatient and outpatient using the cost to charge ratios calculated in your cost report. But professional fees, as we know, or anything paid on the physician fee schedule are not cost-based reimbursed. They are reimbursed through the fee schedule. So for some critical access hospitals, you can have enhanced reimbursement opportunities for professional services if the provider reassigns that benefit. There's an optional all-inclusive method 2 billing that could be more beneficial for reimbursement for some critical access hospitals. Billing professional charges on the UB04 instead of the 1500 allows a different type of split for reimbursement. So professional services could be paid at 115% of the fee schedule, and then facility or technical services are reimbursed at 101%. So again, this is a recap of a previous slide of just kind of the overall Medicare cost report reimbursement process and how you walk through the different pieces of the cost report and ending at your settlement calculation. So we'll talk about a little bit about the A series and some of the opportunities there. The B, which is the allocations of the overhead expenses to your reimbursable sections. C is your patient charges, how we should handle those and some areas that critical access hospitals should look at. And then D is not simple, but it's important. That's where you assign all of your Medicare PSNR data in the cost report, which goes into your calculation for critical access cost-based reimbursement. So expenses, this is what we call the A series. This is where they're included. You should always start with your facility's trial balance. Ideally, the trial balance will match your audit or internal financial statements. You split your expenses between salaries and all other expenses. And then you have different cost centers. So your cost centers are where you're going to assign or map these expenses to the appropriate line number. So you have your overhead type expenses, which are your general cost centers. That's administrative and general, capital related expenses, nursing administration, dietary, all of the cost centers that are going to trickle down to other departments of the hospital. Your reimbursable cost centers are typically patient driven. So those are going to be things such as your operating room, radiology, laboratory, physical therapy, occupational therapy, drugs charged to patients, etc. And then finally, your non-reimbursable cost centers are expenses that Medicare deems non-allowable through your normal course of business. So they're not going to, Medicare says they don't want to reimburse you for expenses that they don't deem necessary to provide good patient care to their Medicare beneficiaries. So there's a full listing of the non-reimbursable expenses in the guide, in the online guide, but so we're not going to go through every one of those, but there's definitely some guidance around those, many pages long. So the appropriate classification for all these expenses in the right cost center is critical for critical access hospitals, because that directly goes into the calculation of your cost to charge ratios. And that is what's used to calculate your reimbursement in the cost report. So one schedule that's a little different for critical access hospitals that's not included in other non-critical access hospitals is your worksheet 883. So there's a limitation on how much critical access can pay for therapy services paid by an outside vendor. So there's a whole schedule that asks for some information and essentially calculates the limit of what you should be able to pay, and then what you actually paid for therapy services. So we recommend always keeping track and accumulating these invoices throughout the year to ensure you have the proper detail to support the amounts in this schedule. So the cost, the hours worked by these individuals, their travel time, the mileage that it took to travel to the hospital, and the number of on-site days is all goes into the calculation of how much you are allowed to spend for outside therapy services. So since there's some additional allowance for travel, overtime, supplies, and equipment, you want to make sure you keep track of those so that can help you avoid an adjustment. Not avoid, but properly calculate your limitation. So moving on to worksheet B. As you know, worksheet B takes all of your overhead expenses, so your A&G, dietary, all of those, and it allocates them in the cost report software. We always recommend letting the software do the calculations. Review this every year. You may think your square footage didn't change, but I guarantee you some office has moved, someone's moved offices, someone's sitting in a different place. So looking at that, your square footage, looking at all your stats each year is very important to get proper alignment of your expenses, of your expense allocations. Small changes could impact reimbursement. I've seen where a movement of some square footage, not even a lot of square footage, had a very large impact, up to $20,000 of a positive reimbursement for a critical access hospital. So it's very important to track all of your statistics throughout the year, either quarterly or monthly, to make sure that you're not using just whatever you had last year. Keying errors could also have a big impact. I can't tell you the number of cost reports I've looked at or reviewed, not ones that we've prepared, but ones that we've looked at where there was just a keying error. They added like 2 extra zeros to one of the lines and like brought a ton of cost down to a cost center that had no business getting that much laundry expense. They didn't even have laundry in this department. But so things like that, always have a second reviewer. Someone at your hospital organization should review it, regardless of if you prepare it in-house, prepare it through a third party. Make sure there's always a second review on this. Direct costing is, in many cases, is preferred. So if you have an exact amount of what it costs to provide some type of service or something that you know is only used in the laboratory department, just go ahead and directly cost that as best you can. Worksheet, some additional areas to look at for worksheet B is changes to your allocation basis. Maybe I'm just giving examples here. Maybe you're new to your organization and this is the first time you're looking at your organization's cost report and you're like, that statistic does not make sense for what I'm seeing at this hospital. Is there a better way to allocate that cost? So for example, I worked at a hospital that was looking at their social work. They had a social work department and trying to figure out the best statistic to allocate that cost. The statistic they've been using for years took them like 4 hours to pull every year. For that statistic, that was a long time. I can't remember the exact, but it was very time consuming. And they're like, I'm not even sure if this isn't even the best way to allocate this expense. And it also takes us so long to pull. We're going to request a change. And so we talked with them and talked through the best way to do that. So they ended up requesting a change for that statistic. Number one, they think it's just as accurate or more accurate than the last statistic they were using. And two, it takes them a lot less time to pull every year. So if you are looking to make a change to your allocation basis, talk with some of your reimbursement folks at your hospital or your procurer. They can kind of talk through the best options for that. The one thing to think of, you can't just change your statistics willy-nilly, as they say. You have to request it by the MAC in writing at least 90 days before the end of your fiscal year. So you also need to include the reason why you want to make that change, which usually if you're requesting a change, there is a good reason for it. There's only been once or twice I've seen where a MAC said, I don't think that's the best. They didn't approve the change, but most of the time they understand. They say, yeah, that makes sense. That should be a change. So moving on to worksheet C. Worksheet C accumulates all of your gross patient charges for your reimbursable patient-driven departments. So like OR, laboratory, adult and peds. It takes all of those charges. You should start with your trial balance. Group all of those charge accounts to the appropriate cost center. But then usually there's some reclasses that need to be made or some professional fees need to be removed. So from that aspect, we typically see organizations pull a revenue and usage report from their system that would have something like the patient status, inpatient, outpatient, clinic, the UB revenue code of what category that charge was in. Was it a 420 therapy account, or was it, where was that charge originated? And then also in that report, knowing what department is mapped in the trial balance. So where did that charge hit the trial balance? So from there, you can see, well, if I'm including all of my medical supplies on this one line, but in my revenue and usage, or in my trial balance, supplies are kind of all over the place. But I don't want to get all this, I need to get all the supplies to this line so I can match them up with my supply expenses. Sometimes a revenue and usage report can help you make that reclass to get everything all together. It also helps you identify any professional fees that may need to be excluded. So those are just removed from Schedule C. So what you end up putting in Schedule C is likely not going to tie exactly to your trial balance, but it's going to be the appropriate numbers. Make sure you have those changes and reconciliation back to trial balance pretty clean, because your auditor is likely going to ask for that. So some other aspects of Worksheet C. Worksheet C is where your cost to charge ratios are calculated. Takes your costs from Schedule B that have been allocated, divides them by your charges, and you get your cost to charge ratio on Schedule C. When you're reviewing your cost to charge ratios, which you should always do, look for reasonableness and compare it to last year. Are there some cost to charge ratios? Is there one sticking out just crazy high or crazy low? You need to be able to explain any significant variances, not only for yourself to make sure that your numbers are correct, but also for your audit if you're selected for audit down the road. Some of these variations could be explained by a new service offering. The first year usually of a new service or department, the cost to charge ratio is kind of wacky to begin with. Or if you're winding down a department, that cost to charge ratio could look a little different. And then always take notes and look at your outlier payments. This is probably more critical. I think PPS hospitals typically have more, from what I've seen, more outlier payments from Medicare. If they're over $500,000, you may be subject to an outlier reconciliation down the road. Keep track of that, make notes, make sure other people in your organization and in your department know that this could be a possibility, especially if your cost to charge ratios are fluctuating a little bit. If they move over 10% and you have over $500,000 of outlier payments, you may have a reconciliation. And so I've seen huge dollars lost through that. And in one case, it was like 6 years after this cost report. So moving on. So some of you may not know a lot about cost to charge ratios, so I wanted to include a little bit about kind of what these numbers mean. So one is like right in the middle. One is like things match what you're getting, what you're charging, and what it costs you is just kind of right there together. If your cost to charge ratio is greater than 1, that means your costs are greater than your charges. So does that mean do you have some costs in there that maybe aren't appropriate, or inconsistent with your department mapping, or maybe there's a professional cost adjustment that should be accounted for. Typically, if I see greater than 1 and it's inconsistent with prior years, was it a low volume year for this department, or is this department just naturally a high cost service? If your cost to charge ratio is less than 1 or closer to 0, this means that your charges were greater than your cost. So you may want to review your cost structure of your service, or costs properly matched with charges. Or did you have a change in your charge master? That is the biggest thing that I've seen recently, is if your organization is making changes to your charge master, make sure your cost report team knows about those changes, because then you may have a surprise when you're preparing your cost report. For example, if you have a department that increased charges by 20%, but the cost stayed the same, or maybe the cost went down because they were able to have some cost savings, they, have a more appropriate number, you may have a large payable at the end of the year. And it may take a year for that to even out, but making sure you're aware of any big charge master updates for critical access could swing your settlements in either direction. So for your PSNR input, just making sure that you run it as late as possible. We say maybe about a month out from the deadline, maybe a month and a half. Medicare is still going to update your cost report with its most recent PSNR to account in any late claims or processing. So for provider-based rural health clinics, we included this section here because many CAWs do have these clinics. PPS hospitals may qualify for these as well, but just kind of understanding some of the advantages or disadvantages of having these provider-based clinics. Some of the advantages is that you may have a potential higher reimbursement compared to being a freestanding physician practice. You have the opportunity to claim reimbursement bad debts. There typically could be more increased physician and mid-level coordination and integration. Maybe those physicians could also be utilized in the rural health clinic, and also maybe do some rounds in the ED or the adult and peds, and then also the benefit of the 340B drug discount program. I'm kind of skimming through a little quicker because I know we have about 6 minutes left, so I don't want to get everyone out on time. So there are, for any new rural health clinics, you're going to be subject to a per visit cap, except for those rural health clinics that were grandfathered in back in 2020. So some areas of consideration for your rural health clinics. So if you have a provider-based rural health clinic, you're going to fill out the Series M in the cost report. You want to review for duplicate allocations of overhead costs. So making sure that we're looking back at Schedule B, where we're allocating all those overhead costs, are you allocating those appropriately, or are we double dipping in some way? That's a common area we see, where maybe we're moving too much cost to the rural health clinic that shouldn't be there. Because the more you keep at the hospital level for reimbursement, if it's more appropriate, that may be better for your hospital to have more with the cost-based reimbursement. Reviewing wages by job code, and consider if any employees float between the rural health clinic and the hospital. There may be a reclass that needs to be made based on time studies, or based on how those employees are tracked in your system. You may know exactly where they spent their time. And ensure your rural health clinic is tracking provider visits by type, which can sometimes be challenging to do. For example, we want to make sure we know what the medically necessary visits are, mental health visits, qualified preventative health visits, because we need to exclude most all other visits from the count. So like nurse-only visits, if your patient comes in for a vaccine, that's not really a visit by a provider type. So some other considerations kind of for strategic planning, focusing on on-campus expansion, which must be within 250 yards of the main provider, expanding services in an already established rural health clinic. Is there something that your patients need that you could already have set up in a current location? And then consider the benefits of 340B. That one's just too big to ignore in some cases. So this last section kind of takes, all of our cost report data. What else can we do with it? There's a lot of things we can do, but we want to make sure you get your CPE credit So we're going to not end our presentation, but we're going to have polling question number 3.
Thank you so much. The third question is, does your organization prepare any additional financial or operational analysis with cost report data? Yes, prior year to current year comparisons. Yes, Medicare or all payer margin calculations. Yes, we use data from other hospitals in our analysis. No, we do not. Or I am not a medical provider. And remember, you must fill out the polling questions to receive CPE credit. Okay, thank you so much for participating in our poll. I will hand it back over to Emily.
Thank you, Caitlin. So we have 2 minutes left, and being respectful of your time, our handouts and slides will be available after the presentation. So I'm just going to skim through the last couple ones. So for Medicare reimbursement analysis, you can use this cost report data to benchmark yourself, run benchmarks against other hospitals, making sure your cost report groupings may vary from your financial presentation, and just knowing that you can use some type of business intelligence analytics or capabilities to help understand some of this data. Some common examples that we see are average length of stay, hospital occupancy, and average hourly wage. These all kind of fit in, especially the average hourly wage, with some of the topics we've discussed today. Some additional examples are here: current year to prior year comparisons, calculating your Medicare margin over a couple of years to see, or is this a good, how are you doing with your Medicare beneficiaries and getting paid for those services? So I provide an example here of a sample margin that we've done for a hospital. The numbers have been changed, and obviously the name has been changed, but just kind of pulling in some of those dollars to see where that margin lands. And then overall, I thought this slide was very interesting. Operating margin trends for all U.S. hospitals. As we expected, negative. It's not great out there. So I thought this was just interesting to throw in, and I know we're at the top of the hour. So I'm going to go ahead and end it here. But thank you all so much for listening, talking about my favorite topic ever. So I hope you all have a wonderful rest of the day.
Thank you for listening to this PYA webinar recast. The video recording, slides, and associated material for this and all PYA webinars are available on our website. If you have any questions or if we can help, please contact us at pyapc.com. Thank you again for joining us, and have a great rest of your day.